Right. So we are recording. So welcome everyone to our joint webinar between the Equadem Network Plus and the Liverpool Dementia and Aging Research Forum. It's fantastic to be joined today by Rachel Thompson, who is an Admiral nurse specifically focusing on Lewy body dementia, working for Dementia UK, but funded by the Lewy Body Society. And we have the lead of the Lewy Body Society here today as well. So just a reminder of our webinar series, we are trying to focus on different solutions and how can we help people with dementia and their family carers and friend carers live well and hopefully address some of those inequalities as well. So you will hear soon from Rachel for about 45 minutes from her talk. Apologies, there was a little notification. And then there will be time for questions. So please feel free to put your questions into the chat box throughout the talk. We will be picking them up and we will ask Rachel all these questions afterwards. But yes, enjoy the webinar. Thank you all for joining. We've already got over 80 people joining us. And over to you, Rachel.
Okay, thank you so much, Clarissa, and welcome everybody. It's lovely so many of you could join us today. So I'm just going to share my slides. Bear with me whilst I get it all up and running. And I'll put it on slideshow, bear with me. Hopefully everybody can see that. Please do let me know. Clarissa, thank you for doing the introduction. As my name is Rachel Thompson, I'm the consultant admin nurse for Lewy body dementia, and I'm here today just to talk to you about Lewy body dementia. What's the difference between this and other types of dementia? Now, it's going to be a lot of me talking, so apologies. I was going to try to do some clever polls, but I haven't quite got around to doing it. So in the meantime, if you've got any questions or comments, please do put them in the chat, and I believe somebody will be keeping an eye on them because whilst I've got my slide showing, I can't really see it. So let's crack on. So the plan for today is just to have a kind of an overview of understanding Lewy body dementia. How does it differ from other dementias? I'm going to talk a little bit about assessment, diagnosis and treatments. I'll then go and talk to you about the Lewy body Admiral nurse service, which is the service I was involved in setting up. And then I'll hopefully have a bit of time to talk through some managing symptoms, some practical tips and advice, leaving a bit of time for questions at the end. So here we go. So just as a background, and apologies, some of you will be very familiar with this information, but really in the context of where does Lewy body dementia sit in relation to other dementias? Well, we know there are about 944,000 people in the UK with dementia. That's the approximation. Not that many people have the diagnosis, but that's how many people we think there should be. And this number is increasing to 1.5 million by 2050, mainly because as a population we are aging and we're living older. Now, majority of people are still living in the community, either by themselves or supported by family members. There are a significant number of people in care homes, and a lot of those do have dementia, whether that's been diagnosed or not. Conservative estimate, I suspect, is 69%. And then at any one point, we still think that 1 in 4 beds in an acute general hospital will be occupied by somebody with dementia. So dementia is everybody's business. We are all coming into contact, and that's obviously why you're here today. Again, this is just an umbrella term. We know this information, I'm sure, but just remembering this, dementia is an umbrella term for a group of symptoms. It's a syndrome, and there are many different symptoms that we may see. So memory, judgment, reasoning, communication, ability to carry out activities of daily living, sometimes changes in mood and behaviour. And depending on the type of dementia that somebody has and the stage at which their condition is, then we will see different symptoms. So let's just have a little reminder of the other types of dementia. Again, this is a broad overview. There are over 200 types or subtypes of dementia. Alzheimer's disease still is the most common. And then it is estimated vascular dementia approximately 20%, but we think probably some of those people have a mixed dementia. Now, Lewy body dementia, here, we'll go on to talk about this, but we think about 10 to 15% of people in the population in the UK will have a diagnosis of Lewy body dementia. That includes both dementia with Lewy bodies and Parkinson's dementia. And we're going to be talking about the relationship between these dementias. But when I say Lewy body dementia, I'm talking about the umbrella term for both of these conditions. We've got mixed dementias, which we often see, particularly when people develop dementia in kind of older age. It's usually Alzheimer's and vascular, but sometimes it's Alzheimer's and Lewy bodies, which again can really contribute to somebody's progression with their Lewy body dementia. And then the other dementias, which we're not really here to talk about today, are the group of frontotemporal dementias, behavioural variant and primary progressive aphasia. People may be familiar with Bruce Willis. This is the type of dementia he's been diagnosed with, and lots of other rarer causes, some of those listed there. So we're talking about Lewy body dementia today. A phrase that was coined by the Lewy Body Society a few years back is the most common disease you've never heard of. And of course, my hope is, and our hope is, that that is changing. But we think it has been the second most common type of neurodegenerative dementias. Now, this excludes vascular dementia because that's not a neurodegenerative dementia. So just to clarify that, because people do get confused. It is actually diagnosed in only about 4 to 7% of all dementias, and some recent NHS England figures on their primary dementia data register actually suggest it might even be less. However, I understand that's something to do with the coding, and when people get given a diagnosis of dementia, there are different codes used by primary care and by memory services and other services. So that's something that people are aware of and are trying to address. But there's been some studies around pathological series. So this is when brains are examined on autopsy, that actually we think Lewy body dementia may account for between 15 and 25%. So actually much more. And this is because it includes people with a mixed Alzheimer's and Lewy body dementia. So about 125,000 people with Lewy body dementia in the UK. And as I said, it includes both dementia with Lewy bodies. This is where cognitive symptoms tend to start first, and Parkinson's disease dementia, or Parkinson's dementia, where people have an established diagnosis of Parkinson's. So not everybody with a Parkinson's diagnosis will go on to develop dementia. We think it's about 30% overall, but the longer people live with Parkinson's, the increased chance they have of developing Parkinson's dementia. So what do we mean by Lewy body dementia? What causes it? There's a picture up in the left-hand corner, which is a stain of an alpha-synuclein Lewy body. These are abnormal protein deposits that essentially disrupt the brain's normal functioning. And we think they may originate in the peripheral nervous system before they travel up to the brain. Now, the Lewy bodies are neurites. Neurites are the kind of smaller particles. But these are, as I said, made up mostly of alpha-synuclein, which is a protein we all have in our brain. We think that's possibly a little bit of tau, symphylin 1, something called LRRK2, which we see in Parkinson's. And tau we also see in Alzheimer's as well, so people may be familiar with that. The alpha-synuclein is folding and forming clumps inside the neurons, forming these Lewy bodies, which essentially change the function, or lead to the change in function or death of the neurons, and the loss of production of some neurotransmitters, which are really significant. So dopamine first, and this is where we see the commonality with Parkinson's, and acetylcholine also, which we see there are loss of production certainly for people with Alzheimer's. Now, it is an age-related condition, although we do see some people who are younger diagnosed with dementia with Lewy bodies. Classically, slightly more men than women. I don't think we really know why. And as I said, that we're not diagnosing enough people at the moment. So what can we do about that? Well, just to say something about the terminology, it is very confusing. And so I often hear people saying to me, I've been given this diagnosis. I'm not quite sure. I'm really confused. I was told it was Parkinson's with dementia, or dementia with Lewy bodies with Parkinson's. Lots of different terms that get described. Essentially, what we're talking about is a type of dementia that shares symptoms with other types of dementia, majority of the Alzheimer's, and also some symptoms of Parkinson's. So the causality behind this is that Lewy body disease, these alpha-synuclein clumps that form in the brain, can lead to Parkinson's. And when they're in the part of the brain that controls things like movement and our autonomic nervous system, this is when people have Parkinson's. Now, as we said, some of those people go on to develop Parkinson's dementia, whereas if they're other type of, in other areas of the brain, more in the cortex, then people develop more cognitive issues often, and this is dementia with Lewy bodies. But this umbrella term we refer to as Lewy body dementia. So this is something called the 1-year rule. It's probably a little bit of overlap in truth between these two, but Parkinson's disease classically is known as when Parkinson's symptoms develop a year or more, when the dementia starts a year or more after a fairly well-established Parkinson's disease diagnosis. So somebody has the Parkinson's symptoms first, and then later on go on to develop the kind of more of the cognitive dementia symptoms. Whereas dementia with Lewy bodies, it's usually the dementia that's starting either before or at the same time as the Parkinsonism, or within 1 year of onset of motor symptoms, hence the reference to the 1-year rule. So, a very simple image of the brain. So I'm not a neuroscientist, but really just, I think it's helpful sometimes to, when we're thinking about different types of dementia and why certain functions are affected by different types. So I'm going to start off with the green areas, which is the temporal lobe, which includes the hippocampus and the amygdala. It's really important memory and emotions. And also our language and speech is quite significantly controlled in this area. So this is the area of the brain that's classically impacted by Alzheimer's disease, but obviously as Alzheimer's progresses, it will move to other areas of the brain and the overall brain shrinks. The frontal lobe, this is the blue area at the front, this is thinking, planning, something we call executive function, and often is related to kind of control of behaviour. And so in the frontotemporal dementias, you will see frontotemporal, that these two areas are quite significantly affected. And so that's why we see more changes in behaviour and perhaps sometimes a little bit less of the memory earlier on. Now, the other areas of the brain, which kind of become a little bit more significant in Lewy body dementia, parietal lobe and the occipital lobe is really quite important. So this area, the back of the brain, is the bit that helps us interpret what we see. And so when people with Lewy body dementia experience kind of visual perceptual changes, we think it's often because this area of the brain has been affected. Now, the other area of the brain that's really important in Lewy body dementia is the brainstem. So you'll see at the bottom here, this is the area that gets affected by that controls breathing, heart rate, balance, autonomic nervous system. And so you will see, and again, so this is the area that is influenced with Parkinson's. So here's some nice pictures of brains. And this is the Braak stages, which is used actually more in relation to Parkinson's, but it's quite helpful just to see that where the Lewy bodies may occur. So you will see on the picture on the left-hand side, the brainstem Lewy body will starting to see what we call autonomic and olfactory disturbances, so the sense of smell. When they move further up into the brainstem, we're starting to see motor symptoms and sometimes sleep disturbances. And then if they move to the cortical areas of the brain, so the ones in yellow, I don't know if I can point my pointer there, but you'll see these ones in these areas. You'll see there's one in the occipital lobe. But these are the areas that kind of involved in emotion and cognitive processing and thinking. So I would like to just show you a very brief clip that's been developed by the Lewy Body Society, which gives an overview of some of the symptoms of Lewy body dementia. So here we go. Hopefully this will work. tips available on the Lewy Body Society website, also on their social media pages, Facebook, LinkedIn. Please do have a look. Please share it with people, because it's really important that people are not often recognising these classic symptoms of Lewy body dementia, which, as you will see, can be quite different to other types of dementia when things like memory are affected classically earlier on. So, what's so different about Lewy body dementia, and what's the difference in terms of the impact on families? Well, we know there are slightly different unpredictable symptoms and perhaps less clear disease progression, but this leads to quite high stress levels amongst families, both for the person with the diagnosis or waiting for a diagnosis and their families. We know there is an underdiagnosis, and I referred to it earlier, and often delays and confusion around diagnosis. So people might fall between services. So sometimes people end up with neurology services because perhaps the Parkinson's symptoms get picked up first. Sometimes people go to geriatricians. They might be picked up in hospital. They might be to speak to the GP. They might be referred onto the memory service. But this lack of these delays and underdiagnosis can lead to anxiety and lack of preparedness for families, which is really quite difficult. There are real challenges in coping with some of the different symptoms. So hallucinations, delusions, fluctuating cognition, apathy is a really difficult symptom that people often talk about. Anxiety and depression, much more common in Lewy body dementia than other dementias. Families, people with Lewy body dementia talk about a lack of timely support and often say that the information they receive, perhaps which is more generic dementia, is less relevant to them. And there's also quite a lot of studies that show there's been kind of poorer quality of life and well-being and higher mortality rates for people with this condition, partly due to the complexity of their different symptoms. So how do we assess and diagnose? So this is a criteria used for dementia with Lewy bodies. What we're talking about, this has actually come from the Diamond Lewy Assessment Toolkit. If people haven't heard of this, please do look it up. You can just do a web search for Diamond Lewy and you will come up with this assessment toolkit and a management toolkit. Really helpful for clinicians. So we're talking about, in the red, these are the essential for diagnosis, so cognitive decline and dementia. What's important is the memory is often more preserved than it is with other dementias. And what we're seeing much more is problems with attention and visual spatial impairment. So you see at the left-hand corner, this is a classic test used for screening in dementia, and you will see somebody with Alzheimer's disease on the left. Their recall was really quite poor, so this is the memory side of things, but their clock drawing and the diagram drawing was really not too bad at all. Whereas somebody with DLB, their recall was actually quite good, but the clock drawing and the diagram drawing were much more difficult for them. So that's the kind of thing we're looking at in terms of the cognitive decline and the dementia symptoms. Now, the areas in blue, these are the core clinical features. So this fluctuation in cognition or awareness or attention can really vary from minute to minute, hour to hour. And people may appear to be sleeping a little bit more. They may appear to kind of drift off or not respond. Another area that's kind of quite different and difficult to manage are visual hallucinations. These may be of people, of animals. Sometimes people are not too distressed by them, but other times they can be really quite upsetting. And people often then go on to develop kind of delusional ideas that they're being watched or somebody's kind of, they're kind of slightly paranoid, that feeling fearful. REM, sleep behaviour disorder, or RBD. This is a dream enactment where people are literally acting out their dreams. So the rest of us, when we are in this stage of sleep, our limbs are paralysed. But for people with Lewy body dementia, this is not the case. And so kind of, bed partners will talk about being kind of hit in the middle of the night. Is very disruptive. It affects the quality of sleep, both for the person, but also clearly for the person who perhaps is in the bed with them. And then Parkinsonism. This is dementia with Lewy bodies. So tremor, rigidity, gait problems, classic signs, stooped posture. People sometimes talk about something called a Lewy lean. People can sometimes lean to the left because their sense of balance is off. The tremor is a little bit more marked on movement than it is at rest. Certainly in dementia with Lewy bodies. There's a lot of symptoms, so apologies. but you'll see there's a whole range of autonomic dysfunction. This is the autonomic nervous system. And I don't know if you remember from the picture of the brain, this is the area responsible for things like blood pressure. So people have a drop in blood pressure, orthostatic hypotension, perhaps urinary dysfunction. This is often a bladder sensitivity at night. So people are getting up much more during the night. Constipation, really quite common. And there's some other symptoms there. And then I also mentioned the neuropsychiatric features. So as well as hallucinations, people may experience a sense of anxiety, depression, apathy, something called Capgras, which is a misidentification syndrome, probably linked to the visual perceptual areas, but somebody very familiar may look very different. And so people think that they've been replaced by somebody. And again, can be very distressing, particularly for family caregivers. So when we're assessing, we're looking for usually 2 of the core features, those ones in blue. Now, if it's possible that maybe one prevalent, and then if this is the case, then the recommendation from the NICE guidelines is that people have an investigation. But just the incidence of different symptoms it varies. So the fluctuating cognitive impairment, we've seen really quite significantly high number of people. Figures vary slightly, but we will see visual hallucinations in quite significant numbers, you will see there. Now, for dementia with Lewy bodies, the spontaneous features of Parkinsonism may not always be prevalent or present earlier on, but eventually they may increase. But worth noting that for some people with DLB, not everybody will have Parkinson's symptoms. So again, this is depending on where the Lewy bodies are in the brain and if they're in the brainstem and the midbrain. And the RM sleep behaviour disorder, this is the specific dream enactment in about 75%, but sleep disturbance is about 90% of people for Lewy body dementia. It's really significant. It's a real problem. Now, tests, screens, scans are really important, and I recognise the value of them absolutely for families. For some people, it may be felt that they don't need a scan because there's so many symptoms, it's fairly obvious, but certainly ruling out other things is really important. So ruling out delirium, ruling out other kind of brain changes through some kind of scan can be really helpful. But in terms of definitive diagnosis, a CT scan will really just show vascular changes. An MRI scan may show some changes in the midbrain, but it's not that sensitive. And if we really want some kind of confirmation, we're looking at a SPECT or a DAT scan, and this measures the uptake of dopamine. So you will see, hopefully, in the right-hand bottom corner, the Alzheimer's disease, you will see there's a good level of dopamine being shown up through those kind of red and white areas, whereas DLB, it's kind of hardly there. There are a couple of other tests that are less used, the MIBG, myocardial scintigraphy imaging. So this is measuring the blood flow. Again, not used that much. I think there is a study looking at how it could be increased in terms of its availability. And then for people who have really significant sleep problems, it may be that they go to a sleep clinic for some polysomnography, but again, may not be suitable for everybody. So when we're talking about the symptoms, there's a couple of studies that people have kind of said, well, these are the symptoms that we find most difficult. So this is a small study, but it kind of matches with my clinical experience. So I think this is a DLB versus some dementia with Lewy bodies versus Alzheimer's disease comparison study. And you will see here that the symptoms that are different for DLB, perhaps not a surprise. So looking right at the top, the delusions and hallucinations are quite significant. Next, I think you will see depression and anxiety, more prevalent, more of a problem. Apathy, really a significant problem for people with DLB. Sleep, again, down there. So there will be some variations depending on, characteristics of the dyad, the relationship between the person and that person's general kind of personality and characteristics. But really, I would say the other things just to be aware of is the autonomic symptoms can be really quite difficult. So the things like drops in blood pressure, constipation, all of these really impact on people's quality of life. So this is just an extract from a gentleman called Daniel Drewback, who was a neurologist who worked with the Mayo Clinic. And unfortunately, his speciality was Lewy body dementia, but he unfortunately developed Lewy body dementia himself. And so I was privileged enough to be able to do an interview with him at the International Lewy Body Conference back in 2022. People are interested. It's available via the Lewy Body YouTube website, YouTube Lewy Body site. And it's just a short interview of him talking very eloquently about how it felt for him to have this diagnosis. But I just wanted to highlight some of his words here. He wrote this piece called Twilight and Me, a soliloquy. And he talks about loss of words being very difficult for him, as you can imagine. But one of the things he's really, so I'm just going to read this bit out because it's kind of quite, it's quite moving really. So he talks about fluctuations are one of the most fascinating and poorly understood neurological symptoms of DLB. My neurologic status, including difficulty with cognition, hallucinations, ability to write, and even play guitar, can fluctuate from week to week, hour to hour, and even minute to minute. At times, I even feel normal and reach a point of ecstasy. I feel the lightness of an eagle and fly higher and higher, only to miserably fall to the ground. What cruel tease. I think this is kind of really quite significant. It really highlights, doesn't it, what an impact this has. So I'm going to move on to share a little clip from a carer, somebody called Karen Young, who's an ambassador for the Lewy Body Society, who is part of a community practice we did actually a couple of weeks ago. I've got a clip of a recording from her talking about what it feels like for her and her experience of being a carer and looking after her husband, Alan. So hopefully I'm going to play this now.
My name's Rachel Thompson. I'm a consultant admin for Lewy Body Dementia. I'm delighted that Karen Young is joining us today. So Karen, just to start off with, I'm just going to ask you if it's okay to share some of your lived experience of caring for somebody with Lewy Body Dementia. So can you tell us a little bit about Alan and your journey as a carer?
Yeah, well, so if I just start a little bit about myself maybe and us. So we've been married for 45 years. We have 4 children and 7 grandchildren. And initially started to notice changes in Alan as early as 2016. So with REM sleep, he was always famous in our family for his very sort of vivid dreams, and we used to describe them as Dad's nighttime antics. But fast forward, we both knew that something was wrong, and 2019, Alan was diagnosed with Parkinson's disease. But prior to that, he had been referred to the memory service in Birmingham, which is where we lived at the time. And really, they just said they did a range of the cognitive testing, and they just said basically just needed to concentrate more. So 2019, a diagnosis of Parkinson's, but for us, it always was the memory issues and the cognitive decline. We saw a range of professionals, neurologists, Parkinson's nurses, geriatricians. Our story was the same. And it wasn't until we moved to Sheffield, finally, in 2022, he had a diagnosis of Lewy body dementia. But it was just a diagnosis. Literally, this is what it is. I asked for information. He said, you can join a support group. That's the neurologist. I said, I didn't really want to join a support group. I wanted to meet professionals. I wanted information. And he just said, well, you can wait 3 months and then you can see a Parkinson's nurse. And that was it. We left the room, and then we saw a psychiatrist who confirmed Alan's diagnosis. But really, the experiences were very different. The psychiatrist gave us 1.5 hours. And I think from that experience, just really felt supported and listened to. And he said if he had just met Alan, he wouldn't have diagnosed him with Lewy body. It's only because he took the time to take the history that he was able to confirm the diagnosis, and the memory service have been absolutely superb. Yeah, I think initially it was just the changes in Alan, that Alan didn't see those himself, and that was tough. But I think that for me, Alan is my best friend. He's my soulmate. You know, we're very different people, but we're a really good team. And I've lost that. You know, I now run the show, and It's not about saying, oh, like, woe is me because I do everything, but things like, you know, practical things like dealing with builders, DIY. Alan was absolutely brilliant at that. And driving, massive was driving, because whilst I do drive, Alan did all the long journeys, and then all of a sudden he could no longer drive, and I became the main driver for both of us. And then it's coping with a disease that's a degenerative disease, and it's constantly changing. And in the beginning it was really, really hard, and I did really struggle with it. And I actually, without being dramatic, I described it almost like drowning, gasping for air when some certain things happened, and I just really didn't know what to do. And I did feel lost in the beginning, and trying to find information. A neurologist who wanted to increase Alan's medication when I knew that the co-carbidopa could increase cognitive confusion, and almost being given a bit of a fait accompli, but not really being given room to be partners in Alan's care, because I think that, you know, we're more than capable of doing that and having the room and the space to do that. So Alan sees, lots of times he sees children and animals, but recently, if he becomes ill, then the hallucinations become more disturbing. He's still able at the moment to differentiate between what is real and what isn't real. But for example, this week, Monday, he came into the bedroom crying because he said, I've seen a child dead. It's lying by the fireplace. It's got an injury to his head. You know, that's really distressing. A few weeks ago, he saw a ball in the bedroom, and he called it out because we don't sleep in the same room anymore because of him acting out his dreams. And I could tell immediately by his voice that he was distressed. But as I said, in the main, Alan is able to differentiate. And for me, I get upset for Alan, because it's not really, you know, that those things are really not very nice to see.
Okay, so I think Karen might have just joined the meeting, but so thank you, Karen, for sharing your very moving experience.
My name's Rachel Thompson.
You probably heard quite a few points, really, like different experiences of the diagnosis, what support was offered, but the real impact. And I think really, if you just think about ourselves and how that might feel, Karen and Alan both talk about their experiences actually at various things, and it's really helpful to just step out of whatever role we're in and just really listen. What must that feel like, and what support do families want and do they need? So again, some things that Karen kind of really touched on and brought out very clearly, that having information, knowing what the symptoms were, what the progression is like, how to manage what caregiving strategies. We also need to be thinking about planning for the future as well. People often talk about managing symptoms. How do I respond when somebody has hallucinations? Apathy can be very difficult, fluctuations also, and sleep disturbance. So people just need a bit of guidance. They need an accurate diagnosis. They also need to know how to access some time for themselves and some respite, so encouragement to do activities and keep active. Peer support can be hugely important for families, and I hear this a lot. So connecting people with other people with the same diagnosis can be absolutely essential for people. And then people talk about having someone to listen to advocate, to guide them. And people talk about wanting staff to be knowledgeable in Lewy body dementia, because that isn't often their experience from various studies. So the Lewy Body Society, here's the website here. It was established in 2006 by Ashley Basin, whose mum had Lewy body dementia. We're about to celebrate the 20-year anniversary next year. And their mission is to raise awareness of Lewy body dementia and to fund research to better understand the disease. Now, this current CEO is Jackie Cannon, who's also on the call with us today, who, again, also has personal experience. They noted that following an increase in inquiries, they wanted to they developed a partnership with the UK and started directing referrals to the Admiral Nurse Dementia Helpline because they realised they didn't have the capacity. It's a small micro charity. And in 2019, funded a 2-year project to raise awareness and offer clinical advice, and created the role that I was lucky enough to get. And so 5 years on, I'm still in the role, and we now have a couple of colleagues who work with me part-time, who are also specialising in Lewy body dementia, which the Lewy Body Society and Dementia UK co-fund. So Admiral nurses, just in case, I'm very conscious of time, so I'm going to start skipping through, but dementia specialist nurses offering a family and relationship centred approach. We offer biopsychosocial support and also education to other professionals. This is the model for the service I set up. I think the important thing is, so it's kind of 2 sides to the role, supporting best practice, education, training, but also some direct support for families. You'll see here that actually our referrals come via what we call the core clinical services, the helpline, virtual clinics, and nationwide. This is the Building Society. We've got a partnership at the moment, and various Admiral nurses are available in nationwide branches around the country. You can get information from that about that on the Dementia UK website. What we would do is we wouldn't work directly with people where there's a local Admiral nurse, because that would be duplication. But we will, if there's not a local Admiral nurse, we will accept referrals for people, hopefully with more complex needs. There are literally only kind of 2 working time equivalent of us covering the whole country. So that's, England, Wales, Scotland and Northern Ireland. This is our referral pathway. So if somebody contacts what we call the core clinical services, our hope is, because we've done quite a bit of training with the Admiral nurses, that their needs will be addressed. And actually that might be enough for that person at that point, because it may be they need access to referral, how to access services, practical support. It may be there is a local Admiral nurse service available. So I would always direct people towards the helpline and their core clinical services first. However, as I said, for people with complex or kind of significantly complex needs, a referral may be made to me or my colleagues. So Rachel Carosi and Sue Kirkup at the moment. Now, after that initial assessment, again, that might be enough for that person, because we've helped them kind of understand what's going on and give them a bit of support and advice. So usually it's via the phone or video call. Our calls are usually about an hour long. And we will provide psychoeducation, emotional support, and this might be to the individual, the person with the condition themselves, or the carer. Sometimes as a couple and sometimes as a family, because when people have extended families, it can be a really good way on video to bring everybody together. So they may be a few sessions, it may be 2 or 3, it may be 5 or 6, and then we tend to review. And then people sometimes do come back to us because, and there may be ongoing need for support. One of the other interventions we offer is the START programme, which is a manualised intervention for family carers. Really good outcomes in terms of anxiety and depression and coping. It is developed by the UCL, University College London, and is available on their website. So if people are interested, it's been slightly adapted for Lewy body dementia. And then we've also been running a carers psychosocial group, which is periodic. We run them about 2 or 3 times a year for a small group of carers over 6 sessions. So that's what we do. Again, I'm going to move quickly on, because I think just to say, the evaluation of my role after a year showed that it was received well, referrals were coming in, people felt it made a positive difference to their understanding and ability to cope. But also the training I did with the Admiral nurses across the country. When I first came into role, we did a pre and post questionnaire, and there were this kind of improvement and knowledge and awareness in all of the areas. So that was really positive. And we do it ongoing for new nurses joining the helpline and core clinical services. There was an external evaluation done by the University of Manchester. There's the link there for people who want to read more. But it was a qualitative study, and they analysed themes. And again, it was really just saying that actually that knowledge of the nurse, the practical tailored support, the emotional benefits gained. So this carers being able to talk to somebody who absolutely understood their condition and knew about Lewy body dementia made a real difference. And the reliability was really important. And people, overall, the conclusion was actually it did make a difference. And on the back of that, then Dementia UK then funded some other Admiral nurses to work with me, which has been great because the referrals keep coming in. So when we do an initial assessment, we use, again, you won't be able to read all of this because it's quite small, but the Admiral Nurse Assessment Framework, this guides all Admiral nurses in their practice. And we're looking at a number of things, health and well-being of both the person with dementia and the family carers. We're looking at how well people understand the condition. Might be practical advice. We might be thinking about what assistive aids people might need, what formal support they have. For families, we're looking at what time for themselves. We talk about advanced care planning, offer a lot of support around adjustment and loss. This notion of ambiguous loss and grief is really quite significant. And then we also may be touching on risk. Are there any elements of risk? And of course, if there are concerns, then we would be alerting local safeguarding or recommending actions for people to call local emergency services. It's a balancing act, I would say, between managing cognitive and neuropsychiatric symptoms and the Parkinson's symptoms, and it's often finding out which of the symptoms are most problematic. There is absolutely a significant role for medication, but also a really significant role for psychological, social and environmental advice and support. So the Diamond Louis, kind of a little bit of a Bible, a go-to for us. It's been reviewed at the moment. I think the new version is due out towards the end of this year, being developed by Newcastle and Cambridge initially, and basically has some really useful, you can just put Diamond Louis into a website and you'll find some really useful advice, particularly around medications. Please do share it. If you don't know it, have a look. Lots of information in there. Just in terms of pharmacological treatment, the NICE guidelines and in other areas as well, other countries, is the cholinesterase inhibitors, either donepezil or rivastigmine, for both early stages and later stages, and then also memantine if people don't tolerate. So people with kind of heart-related problems, bradycardia, for example, a slow heart rate, may not tolerate the cholinesterase inhibitors, so they may be offered memantine. But there is a study, the COBALT study at the moment, which is looking at whether the combination of these two actually is really quite important for people with Lewy body, and we'll await the outcome of that study. Again, I've overshared, so apologies. It may be that it's possible to share some of the information after, but there is a lot of information on the Lewy Body Society website. Talked about the pharmacological interventions. I think just things I want to highlight here are hallucinations can really respond to cholinesterase inhibitors. If people are on Parkinson's medication, you may need to think about reducing those because they can increase hallucinations and can, as we heard from Karen, impact on cognition as well. If they're really persistent, then maybe cautious use of an atypical antipsychotic. Sleep is massively problematic. Sleep hygiene is your first go-to. You know, are there practical things you can do? But also sometimes melatonin can be helpful because it has very few side effects. Whole range of this is actually all in the Diamond Louis, so I'm not going to dwell on this, but please do have a look because there are multiple problems. But I guess it isn't just about pharmacological things like exercise, occupational therapy, speech and language therapy, equally really important. So we have developed a range of information leaflets that are available on the Lewy Body Society website. You can order them. They're also on the Dementia UK website. We developed them with people with lived experience, and there's some very practical tips about what to do. So visual hallucinations, delusions and capgras, just thinking about the environment, thinking about are certain things making it worse, actually asking for a review of medication. And some of the work that we do with families are often around that knowing what to say, how to manage it, to kind of reduce their own stress levels, because this can be very difficult for people. Managing sleep disturbance, again, it may be that it is to do with other symptoms, not just the REM sleep behaviour disorder. So ruling those things out, see if there's anything that can be done. The sleep hygiene, thinking about timing, routines, keeping a sleep diary just to monitor, but again, maybe possibly thinking about some medication if it's very problematic. Lots of information on there. We work with a variety of people with different problems. And as I intimated, we may be offering support around understanding symptoms, coping strategies, understanding medication. But we do get referrals for people with often quite complex needs. And here's just a few examples of some of the work we may have done with people in the past. So support around transitions can be very difficult, accessing peer support, finding out who to go to, empowering people with the knowledge and confidence to ask for the right help, and perhaps sometimes just being that person who understands what people are going through. These are some outcomes from our psychosocial or psychoeducational group. We've had very positive outcomes so far in terms of improved knowledge. Obviously, there's always room for further research, but certainly it brings people together and gives the opportunity to be able to say, I know what that feels like, and there's a lot of comfort gained from that, and people can get tips from each other. Some of the solutions, this is based on the evidence. So essentially this summary is tailored intervention should be offered one-to-one or via a group. People affected by Lewy body dementia needed targeted information about their symptoms, which are often different to other types of dementia. I mentioned about the START programme. There's also some evidence about groups. I've spoken about our group, but things, peer support groups such as rare dementia support or locals care groups may be really important. And there's also increasing evidence about an approach called ACT, acceptance and commitment therapy, and helping people adjust and focus on things that help them focus on the positives rather than kind of getting too caught up in the negatives and the disabled model. So here's a link to the resources. We will be developing more resources as we go along. My next one is around fluctuations. Again, I feel like I've been saying that for a while, but it really is a problem, and I'm really keen to do something around that. And just before I finish, I wanted to mention the Lewy body community of practice. We've got over 350 members now. This is specifically for nurses and AHPs interested in Lewy body dementia. And we have been doing a range of webinars. You can access all of the recordings on the YouTube Lewy Body Society area. But we've been getting really positive feedback, and we're really wanting to do more and more. I think the reason I wanted to mention it today was that we are really actively looking for some people to join our steering group. So we've had a couple of people retire from roles recently, namely physiotherapists. But if you are interested, you're in one of those roles or from social care or psychology background, if you want to get your phone out and scan the QR code, please do, or you can email. But the information is on the Lewy Body Society Community Practice page of the website. So please do have a little look. I've got to the end. Hopefully that's okay. Here's some information about the Dementia Helpline if people want to find out about making referrals. And the Lewy Body Society website is there. And I'm going to hopefully end this. So
great, thank you so much, Rachel. That was great.
I'm going to stop sharing.
Yes, that'd be great. So now, everyone, if you want to post your questions into the chat, and we'll be picking them up. But I've got a first question, perhaps, whilst people want to feed in any questions into the chat now. And there's already some thank yous coming in, Rachel. I know you've mentioned on your last few slides there is some early ideas of possible solutions of how to support people with Lewy body dementia and their families a little bit better. But honing in on your role as an Admiral nurse for this particular subtype of dementia, and looking at the numbers of people that are already affected by it in England, in the UK alone, it seems like there's not enough Admiral nurses available to help everyone. Is that right? And what's your call for more funding, perhaps, to support people better with that role?
So Dementia UK are kind of the organisation that will work with organisations to get Admiral nurses established. So if anybody's in an area where there isn't one please either talk to people who can hold the commissioning purse. We need to prioritise this. Dementia affects so many different people. And in terms of specialist roles, what I would love eventually is there are more kind of locally based admiral nurses who can specialise in Lewy body dementia. But having said that, admiral nurses will know a fair amount about Lewy body dementia and can always come to myself and my colleagues if they need any more kind of detailed information. But yes, we need more, Clarissa, I think. So, but in the meantime, if you don't know if there's an admiral nurse in your area, do call the helpline because they'll be able to advise people. So
great, thank you. We've got a question from an Australian participant, which is nice to see. God knows what time it is there now, very late in the evening, I think, at night. So a question from Marta. Can early diagnosis and strength-based engagement interventions, so maintaining skills and abilities, slow the progression for Lewy body dementia?
Yeah, really good question. So there's a lot of evidence, particularly dementia globally, but also for Parkinson's, around the importance of exercise, activity, cognitive stimulation. So I would say yes, absolutely. Focusing on people's strengths is hugely important. Overall, people with Lewy body dementia do seem to have a kind of quicker progression, unfortunately. There are high mortality rates, and it may be just because the complexity of the symptoms, particularly around when people get more Parkinson's symptoms, so things like aspiration, chest infections, deliriums can really contribute to progression. But I would always say, yes, exercise, activity, engaging, social stimulation, focusing on people's strengths rather than their deficits, really, really important for us. So, yeah.
Question from an unpaid carer herself, and I'm not sure whether you might be able to answer this or whether Jackie, the CEO of the Lewy Body Society, might be able to answer this. Do carers working in care homes, so adult social care staff, have training, or rather have enough training about Lewy body dementia and Parkinson's disease dementia? Rachel, Jackie.
Do you want to go with that one, Jackie?
Okay, thank you. I would say no, they don't, because as a charity, we have seen an increase and continue to see an increase in calls from family carers who are struggling to place a person with a Lewy body diagnosis in a care home, or are being asked to remove that person from a care home due to lack of training of staff. And it's not the staff, it's the fact that there isn't enough investment within the care home community in dementia training. And unfortunately, the people living with that diagnosis, the family carers don't know where to place these people, and it is really becoming a struggle. I personally have gone into a number of care homes recently delivering, I wouldn't say training, awareness sessions about Lewy body, and you can see the staff saying, oh, we've got a client who's got those symptoms. They don't have a formal diagnosis, but we've got a client who's got those symptoms. So yeah, there's definitely a long way to go in terms of care home staff training.
Okay, thank you. And one final question, I think, unless anyone else wants to pop anything into the chat. I'm not sure whether you, Rachel, are able to answer this. You might. Why do we have a lack of admiral nurses in Northern Ireland?
Yeah, I saw that, Clarissa, in the chat. So, Steve, very good question. We've got an admiral nurse who's working into clinics in the nationwide branches in Northern Ireland at the moment. I know Dementia Care are very keen. Would love to. I think it's often just about certain countries, regions, Scotland equally, that we would often just have different ways of doing things and commissioning things. But I do think absolutely there is a role for admiral nurses in all areas, and we'd love. So if people do have any connections with commissioners in Northern Ireland, I've been over there a few times, and I know we've got some advocates over there. It is often about funding, isn't it, Clarissa? I think that's the sad thing. But yes, thank you for the question, Steve. Let us know if you've got any suggestions. And I can see there's a few admiral nurses putting some information. Thank you, colleagues. Lovely to see you. But yes, there are admiral nurses. And I think some admiral nurses do work in providing training into care homes, following Jackie's question. So again, find out to the local admiral nurse and see if they can put something in. And thank you, Joe, for putting the link in the chat for the nationwide clinics.
Great, thank you so much. I think based on the chat, and yes, it is great to see other Admiral nurses joining us to this webinar today. That's it. So thank you everyone for joining. Thank you, Rachel, for a really great presentation. And as always, it's nice to have a more positivist approach as well towards the end, instead of just highlighting how difficult it is, because it is hugely challenging, but any little positives we can gain, that's great to highlight. So thank you, Rachel, and thanks, Jackie, as well for joining us. We will hopefully, we're in the process of setting up another webinar between Equadem and Liverpool Dementia and Aging Research Forum, possibly for November, December, but you will get it in your inbox soon. So thank you all for joining, and hopefully see you soon again.
Thank you.
Bye,
can I just
everyone.
have one last question, because my mic is not working, so I'm just thinking if I could do. My name is Sarah. I'm one of the nurse. I just want to find out a little bit more about Admiral Nurse in terms of training for domiciliary cares. Are they be able to do in London?
So thanks, Sarah. I think probably the best way, because of time, is to go onto the the Dementia UK website. There's lots of information about finding out how to be an Admiral nurse on their website. There's certainly some kind of free training that you can access. So do have a little look. I think that's probably your first point of call, and you can sign up for updates as well as posts appear and as they're advertised. So I think that's probably the best thing to say.